we'll get started. All right, so I have Kelly here, Dr. Tillotson again with me. There may be another physician that's going to speak a little bit too, which is Dr. Aaron Seitz. He's the director of trauma at Westchester Hospital. Dr. Richards is here with us. And then Lieutenant Lovell from the police department is going to talk about some scene preservation stuff with us, making sure we're all aligned and continuing our partnerships with our internal and external organizations. But without further ado, Kelly, go ahead.
All right, so I've got 3 cases for us to go over today. And the theme of the day is trauma, which is everyone's favorite. I also apologize, I have one ear that's not working right now. So if I seem like I'm ignoring you, I promise I'm not, I just can't hear. So please feel free to speak up. So first case is we've got a GSW to an extremity. So, crap, it's just like, see my slides. So this was a 16-year-old patient who had a firearm in his pocket and it discharged going through his foot. Our medic 71 got dispatched out there to help take care of him and found him sitting on the couch with a ballistic injury through his left foot. The assessment for the patient showed that he had appropriate airways, had no signs of difficulty breathing, but did have a tourniquet that was placed by Westchester Police, and there was still some bleeding noted at that time. The initial assessment that was done showed that he had some tachycardia and a little bit of hypertension, was satting fine on room air, and showed that after placing a pressure dressing of the wound, the bleeding was in control at that point, and they left the tourniquet in place. Otherwise, no other significant findings were noted in the assessment portion for the patient. I did like that they put on, the team that took this put in there that they were able to see the ballistic injuries. We'll talk about some of the documentation stuff in a little bit. Otherwise, rest of his assessment was completely appropriate. The team, when they, there goes 75. Interventions done by the team were placement of an ABD and then wrapping on top of it for a pressure dressing. Put him on the monitor, started end-tidal, placed an IV, and gave the patient 25 mics of fentanyl, and then also checked a glucose, which was appropriate. The rest of the assessment for the patient and management showed that they, after a controlled bleeding by placing the pressure dressing, they took him to UC. After getting the fentanyl, he was a little bit loopy, so they declined to give him further medications for pain control or anxiolysis. Otherwise, took him to UC and was brought in as a trauma stat due to a tourniquet placed. The patient at UC was found to have 2 metatarsal fractures that were considered open given the ballistic injury through them. There was no vessel involvement in it, and after they took the tourniquet down, were able to manage the bleeding with just pressure appropriately. Podiatry ultimately ended up being consulted and decided to take the patient to the OR for washout and management given the concern for a potential open fracture with ballistic fragments present. But he went home immediately after that procedure was done and has been doing okay on the follow-up that I could find for him. So for extremity gunshot wounds, these are actually relatively common, but I struggled to find a ton of data on how you end up taking care of them. One of the review articles that I found that was actually the orthopedic literature acknowledged that as well. So I'm glad I'm not alone in that front, but they said there's not a lot of data on the specifics of managing these wounds. The biggest things is that the next steps in management typically are determined by what is injured on the patient. In the extremity assessment, the big things that you're going to want to look at is the gross musculoskeletal involvement. So is the wound obviously deformed from a compound fracture, other fracture of the bones involved in the extremity that's affected. Some of these ballistic injuries, depending on the projectile that's used, can end up having a shatter pattern when they hit onto the tissue and can have some decent soft tissue damage. But most of the ones that I've seen so far in my career end up being more like the ones that I put on the screen, where it's more of a small wound without a ton of soft tissue damage visible on the skin layer. You may find some fractures with it, which if that's the case, I would recommend doing something to stabilize those fracture fragments, because what we would not want is if those are unstabilized, having a fracture fragment pop out and then creating a true open fracture with a bone sticking out to the rest of the world. The next thing that you're going to check is the vascular involvement of the limb itself. The biggest concern that people have with ballistic injuries to extremities is that the bullet is going to end up hitting some of the neurovascular bundle, either with the projectile itself or with the shock wave going through the tissue. So in any of those extremities, you're going to want to check that they actually have appropriate pulses. And another big one that I'm an advocate for is actually capillary refill, showing that you've got good movement of blood into the tissue, but also blood out or movement out of the tissue. And that one's pretty simple, either like pinch their finger or pinch their toe. And it should go from a yellowish color back to pink in under 2 to 3 seconds. And that's a good indication of distal perfusion. And then the next one is a gross nerve assessment. And for that one, usually when I do these quick in the ER, it'll be, can you feel me like touching on your palm, touching on the back of your hand, and then same thing on the foot. And if not, you can drill down even further. Like, do you feel me at all on your hand or your arm? That at least gives you an idea if there's some really severe nerve involvement in it. And then the other biggest part that ends up being talked about is bleeding control. So the two ones that are probably the less invasive would be things such as a pressure dressing or packing. Pressure dressing was done by our team after they said they were still having bleeding from the tourniquet. And the one that's described having the most effect is taking a type of gauze, like an ABD was the one that I found most commonly in the literature. You put that on top of the wound, put like even another thing on top, like a ACE wrap, or here they have like a Curlex that they have right on top of the initial bandage. And if you put that there, that when you wrap the wound ends up putting that direct pressure down into the wound itself when it's rolled up with a Curlex or a second ACE wrap. Some wounds, say on the torso, don't actually work very well for having these types of pressure dressings. And in those scenarios, most of the time what I found in the literature was doing packing. So something such as combat gauze at that point to try to put some pressure inside of the wound, spreading out onto the bleeding vessels. If those are not possible, or you have some greater vessel involvement, that's usually where tourniquet application comes in. Most of the stuff that I found is that the indication for putting a tourniquet on is to get rapid control of severe bleeding. This is typically described as being from an arterial bleed, so you actually have like regular spurting of blood coming from the wound, or a major venous involvement, such as like laceration of popliteal vein or like a femoral vein that's causing a significant amount of bleeding that's going to cause them to exsanguinate. But the arterial one is the most commonly described. Most of us now carry the CAT tourniquet, which I apparently found out is a misnomer. It's the combat application tourniquet. So if you're saying CAT tourniquet, you're going CAT tourniquet tourniquet. That one is was validated by the US military as well as some of our other international colleagues. And that one has a pretty simple application process. But when I teach this to people, what I found is that one of the problems people have with getting control of the actual wound for bleeding is we don't use this to its full advantage. So you've got your tourniquet with this huge long huge long piece of Velcro on here. If you're going to put it on, the problem with the windlass is it has about 1 to 2 turns before you lose the ability for the windlass to be effective at actually completing the occlusion of the blood vessels. So the best thing you can do is tighten this strap as much as you can, even indenting it into the skin before you even mess with the windlass. And sometimes with that, you'll get enough of the venous compression that you only really need like 1 turn of the windlass before you actually get your arterial compression. Most of the tourniquets that I've seen that people put them on, they don't pay as much attention to that step of tightening the initial strap, and that makes their windlass spin much less effective. So that's one thing to pay attention to when you're putting tourniquets on. And the nice thing is that this is something you can practice on yourself. You can actually like take one of your tourniquets if there's one in a training square or you found one that's about to expire, and actually see how much pressure it takes to really pull this thing tight. And you can see very quickly, like on my own hand, it's going to start to turn white for me pushing most of the blood out of there. And I haven't even done anything with the windlass yet. Other things that for tourniquets, never put them over a joint. And the main reason is they won't work. Over a joint, you end up having a lot of movement of the tissue, which will dislodge the tourniquet. And then the other thing I have to say, because I know this was AirCure CQI, please do not put a tourniquet around a neck. That is not helpful. That did actually happen. It was not Westchester, but it was another fire department where that happened. So no tourniquets on the neck. The other big thing that people talk about with a tourniquet is where you put it. Most will say get it high and tight, so like high up on the extremities. So say if I had a ballistic injury on my mid forearm, some people would say to actually get that tourniquet up onto the bicep so that you have a fair amount of space between the two that can be used to further assess or pack the wound if you need it. Others will put it like right next to the wound. If you do that, just make sure that you've got enough space between the wound and the tourniquet itself that it can be appropriately assessed without having to remove the tourniquet, or that the tourniquet, God forbid, will not then fall down into the wound itself.
Can we jump in here real quick?
Please.
So the only other thing, if you want to go back to the other
Yeah.
real quick, that I just want to highlight is that first bullet point, which is, and it probably goes without saying, but I'll just say it anyway, but tourniquets are really meant for arterial bleeding, right?
Yes.
And so if you truly are dealing with like gunshot wound to the foot, you're probably unlikely to be encountering life-threatening arterial bleeding. Maybe not, I mean, potentially.
No.
But you're probably more likely to be encountered like venous bleeding or like brisk venous oozing. In those situations, actually tourniquet application may actually make things worse from a bleeding perspective than also control. You can actually like, get a point where like you'll obstruct venous return, and so then you'll actually end up with like pooling of venous blood into the area of venous injury, actually potentiating and worsening your bleeding source in that situation. So just while we're here kind of talking about point one, like, you know, if there's brisk enough bleeding, you see pulsatile bleeding, and you think their pressure is supporting like that kind of flow, like that's really kind of where the tourniquet has its benefits. If it's brisk venous bleeding, then we'll think more about like the direct pressures if we can stay on top of it.
And interestingly, when I was looking through some of the literature on this, there's actually some of the, I think it was an article I found in like American Surgery, where they were talking about that this might be one of the overuses we're seeing in pre-hospital medicine of tourniquets, because they mentioned that if you might not be causing more harm than good if you're using it for minor bleeding that could be, or like, you know, minor, where it could be controlled with a really good pressure dressing. But we've noticed over the last several years, like tourniquets were introduced after World War II to be effective bleeding control measures, and they certainly are. But they have seen a huge spike like over the last 10 years of tourniquet use in general. And there's some discussion in some of the surgical literature about trying to decrease their use unless it's in some of these like major arterial bleeding situations. And then the other thing too that I'm a firm believer that if you're going to put a tourniquet on, you want to make sure that the distal pulse is absent, like actually like do the job of the tourniquet. The tourniquet job is to stop the bleeding, and one way to make sure that you're going to stop it is inhibiting any further blood flow to the limb. So say if you put a tourniquet on a wrist, you then want to make sure that you have gotten enough control that you have an absent radial pulse to make sure that you're not having that further blood exsanguinating into the out into the world. Because that's really the reason of a tourniquet, is to prevent them from having massive hemorrhage that's ultimately going to kill them. So in that case, I would argue that you should go until you have like absence of a pulse. I know there's some discussion on that, like maybe that's, you only need to go until bleeding is inhibited, but that's the camp I fall in. I don't know if you disagree with that, Dr. Richards.
No, I think it was especially if you're thinking about it, and then, you know, if you end up having a little bit of resuscitation and you end up with a better blood pressure.
Yep. All right. And then the other thing that people always wonder about is what actually ends up happening with these patients when they go into the hospital. And this is where some of the literature that I was having some fun digging into. Currently, most ballistic injuries to a limb, they end up being washed out and going home without antibiotics unless there's a fracture involved. If there is, standard fracture management will be done. And some of the more severe ones, like the image that I have up here, they have this severe compound fracture. It may require a more intense orthopedic intervention, such as like some external pinning to help put the fragments where they need to go. But a lot of times it's managed just like your standard fracture with either surgical or immobilization, depending on the fracture pattern. Most end up not getting antibiotics. There's some discussion in the literature that this might be because the ballistic is fired at such a temperature that it burns off all of the bacteria on the metal itself. The article that I have up here, they did some, there was a couple studies that were done that showed that that's not the case. That they actually were able to culture off the same strain of, I think it was Staph aureus, when they fired it into ballistic jelly after like inoculating it with it. So it does show that there is still bacteria present on these projectiles. But regardless, what we found in the trauma like case reports is that just by actually cleaning the wounds out and doing good wound care, you don't necessarily have to do antibiotics unless these progress to infection. And then the only times that people tend to go in and actually get the ballistic fragments out is if they are in a joint in the spinal cord, because at that point there's concern that the lead in the ballistic fragment can leach into the rest of the synovial fluid and then actually spread to the rest of the body. Otherwise, if it's say like deep in the muscle, like the ballistic fragment is here, where it's not near the skin, oftentimes they'll just leave it there, and even times over years, the body may push that fragment to the skin, and then at that point, you can make a small little cut with a scalpel and pull the fragment out as an outpatient. There's Dr. Seitz.
Yeah, so if someone's like, you know, calling in and say like, hey, bring me in to get my like bullet taken out or something like that, that's not something like
They don't have to go.
actually happens.
Yeah.
What we'll probably do is like refer to Dr. Sites and try
Yep.
a clinic or something like that, and they can schedule something. If it's popping through or infected or these sort of things.
Yeah.
Or, you know, then actually, and Lieutenant can kind of speak to this, you know, a little bit later or now, but you know, you might then have like chain of custody stuff. Like if it's like years out, like you're maybe not, but like it's just probably more trouble with this one, to be honest. Just think
Yes.
something out that's not causing it.
I think that's the big set that I have on case 1, and then case 2 and 3 are kind of variations on a theme. Any questions?
Yeah, I just talked to Woody. They're gonna probably re-invite everyone and locked up at the threes. Trevor, get that fixed.
Yeah, I'll get right on that one.
Locked up. No, we've been trying to get them to fix that for probably going on 3 years now.
IT? I told you doing it at the threes is probably a bad idea. They're allergic to the EMS thing down there.
It'd say that. I give you that.
Even their technology doesn't want any part of it.
Got it.
Everybody else go on? Three.
All right, we see you.
Well, that's progress. There's,
Hear us.
can you guys hear us okay?
Yes.
Awesome. All right. Yes. Oh, for heaven's sake.
We can see if it's still recording. Kelly wants to make sure.
Yep. Oh, for heaven's sake. All right, can you guys see the screen okay? I got a thumbs up from sites. And screen share, it looks like we're recording. Okay. Sorry, guys, we were pivoting from my laptop. Fun times. All right. So, the two cases that I have, are a little bit of variations on a theme. We have one that was initially dispatched as a non-breather ended up having a gunshot wound to the chest. So initially, MD-75 was dispatched, and when they arrived on scene, there was a neighbor that said that had concern about the patient, that he was not breathing well and had fallen down. The team followed a blood trail in, and then when they found the patient lying on the floor in his house, patient was breathing spontaneously and talking in full sentences, lying in a pool of blood with his shirt covered in blood. Patient said that he had shot himself with a .45 handgun in his chest twice due to some disgruntlement with his significant other. On the exam, they took his shirt off and found a hard lump with emphysema on his chest, as well as some wounds over the anterior chest. They noted that there was seeping and bubbling from the wound when the patient exhaled. On the back, there was another small wound over the scapula that was not bleeding as much. Patient had a blood thinner that was unknown and denied other symptoms. The documentation notes that there was no tracheal deviation on the patient. They put him on a backboard, put him in spinal immobilization, and then took him out to the medic unit and put a halo chest seal on him. The second chest seal got put on his back and noted that the patient had appropriate vital signs. They did burp the chest seal as well. When that happened, they would have removal of air from it. They did note on examination that he had some diminished lung sounds as well on his left chest. So you can see on the vital signs, his heart rate is actually normal. He's a little bit tachypnic, but statting 96% on room air with appropriate end tidal and GCS 15. The assessment, I think, could probably be a little bit more buffed up for this patient. They do note that at least the primary survey is overall preserved, other than a weak radial pulse. Interventions that were done for the patient: he was put in spinal precautions, got on the monitor, started him on oxygen.
Can you put the slideshow on presentation?
Maybe.
If you're having difficulties.
Maybe. Shoot. Do you remember which button I pushed for presenter mode?
You stop share. Up there.
Okay.
And then hit share.
Screen share.
Mhm.
Sorry, guys.
There you go.
This one?
Yep.
Okay. Better?
I'm making sure, but then we'll just have to, you guys already continued sharing, right?
Yeah.
Yeah, perfect.
Okay, cool. 2 IVs got put in and was given a 250 bolus of saline. Other things for the patient is that while they were getting ready to transport him, noted that he had some diminished lung sounds on the left side of the chest. And they took the decompression needle out and identified the appropriate landmarks. And ultimately decided that, considering that his hemodynamics were appropriate, decided to not proceed with needle decompression of his chest. At Westchester, too far, he ended up having a significant amount of, apologize, this is actually from our other patient. But he ended up having a significant amount of chest wall trauma, which included a left hemopneumothorax. He had chest wall hematomas, had a scapular fracture where the ballistic fragment had hit his scapula, multiple rib fractures, and also had a splenic lac as well. He ended up having a chest tube placed at Westchester Hospital, and the decision was made with these injuries to take him to UC downtown. Prior to that, he was having some more agitation, and the decision was made to prophylactically intubate him prior to transport via helicopter for patient safety as well as crew safety. And then he got transferred to UC Medical Center and admitted to the SICU there, which based on the follow-up that I found there, it looked like he ended up having chest tube in for a while, had a cardiac evaluation due to some pre-existing cardiac injuries, but ultimately no other, I was not able to find a lot of other significant interventions, but if Dr. Seitz had a chance to see some of these, I'd happily take his input.
No, I
Otherwise,
think you got,
go ahead, Dr. Seitz.
no, I think you had it. I think that the management was appropriate for how he presented. I think, that decision on whether, additional decompression of the chest is necessary is kind of the key factor. But since his vital signs were doing okay, probably wasn't necessary. So yeah, but that was handled well. I'm pretty sure I was the attending when he came into Westchester, if I recall.
I think you were, yes.
The only very minor point that I'll buff on this one is that, at least in the documentation, it did say that the C collar was placed.
Yes.
And I think if it's like an isolated gunshot wound to the chest and they're not like an arrest, it's hard for me to know kind of where the indication for that was. Even if it's a penetrating neck injury, the protocol would say hold off on C collar. And that's kind of more like access issues, but also like wrapped into like an overall like pretty low incidence of like high C spine injury from penetrating neck trauma. So that may have just been rote one way or the other in terms of that, but just to kind of mention that, because that did kind of pop out to me when I saw it.
Yeah, agree with that. Thanks for bringing that up. Because that's my understanding as well, is that in like setting a blunt trauma, patients are able to provide further history, something like that. You might have a better indication for putting it for someone who says, I got an argument with my wife about going into a nursing home, isolated ballistic injury without neuro deficit. I think it makes sense to hold off on that at that point. Otherwise, I think their management was appropriate. The second case was dispatched as a auto crash and was a motorcycle versus a car. So in this case, it was Medic 75 got dispatched with concern for a motor vehicle crash and found a motorcycle versus car. The description of the scene was that there was an SUV that the motorcycle crashed into. And when it crashed, the bike ended up being flung about 30 feet away, and then the patient was flung from the bike as well. No helmet on scene, so this was presumed to be a non-helmeted MCC. The bystanders noted that there was someone else who was injured, so a second medic was ultimately requested to help with the second patient. Our patient in this case was found prone with cuts on the face and legs and arms, some obvious facial deformities, bleeding from the mouth and nose, and blood coming from his head, which was described as about 50 to 100 cc's of blood on the ground. Also, noted that he was, initially GCS 15 for him with some tachypnea and, slight increase in his respiratory effort. This patient was put in a C-collar, with concern for potential back injuries, and they discussed maintaining C-spine placement with the scoop. He had some head trauma that was noted, including a, posterior temporal, laceration, and managed this with a pressure dressing. He had appropriate pupils and was ultimately taken into the medic unit. There, they appropriately stripped him down to look for injuries, attained IV access, started him on end-tidal monitoring, and they noted that he actually had clear lung sounds, but had mostly like facial trauma, including missing teeth, laceration of the nose, etc., as well as a deformity of his, I believe it was his left collarbone. No significant chest pain, abdominal pain, and staple hips for evaluation. While en route, he became increasingly more agitated and saying that he wasn't able to breathe, his back was hurting. They had difficulty even attaining vital signs for him. And there was some concern that him having this increased difficulty breathing, that he may require a needle decompression. When this was mentioned, the patient was no longer directable and became more agitated, but they also very shortly after that arrived at Westchester Hospital. So again, in the documentation, they're able to find that he had a O2 sat of 93% on room air and was tachypnic, but were not able to record an appropriate blood pressure or pulse. Noted he was GCS 15, and they did note he had chest expansion that was symmetrical, airway was okay, and had appropriate circulation on his primary assessment. Kept him in spinal precautions, IV and monitoring, and then got him to Westchester Hospital. This gentleman ended up having a multitude of injuries. His biggest one was that he had significant spinal cord injuries and extensive rib fractures bilaterally. He had ribs 1 through 6 on the left and 8 and 11, as well as 3 through 10, I believe it was laterally. On the right, he ended up having 1 through 7 that were broken, had hemopneumothoraces, pulmonary lacerations, ended up having T-spine fractures, as well as a parietal skull fracture, clavicle fracture, scapular fracture, and some fractures of the nasal bones as well. What's that?
No, hold on, this is all of those. No. Park Ridge.
One second, Dr. Sites.
If you want to keep doing presentation wise.
For recording.
But this is in Westchester, so.
Yep.
Everybody's going, I'll be back then.
Okay, all right. Sites will keep going if that's okay with you. Sounds
Yeah,
like.
no problem.
Okay. So then on my chart review for him, it looked like he had some initial stabilization at Westchester and then was transferred down to the SICU. And what I could find was that he had rib fixation that was done while he was there, but looks like most of his ortho stuff was managed non-operatively. I don't know if you had a chance to look at this gentleman at all, Dr. Sites.
Yeah, I think again, things were managed, I think, pretty appropriately. His chest wall trauma was probably like his sort of biggest thing that probably caused the biggest concern immediately, as well as his spinal cord stuff, or spine fracture stuff. But if I recall, he was, immobilized appropriately. Did he get? I think he got a chest tube, correct, in the ED at Westchester.
I believe he did, yes.
Yeah. And if I recall, it put out, a fair amount, but it wasn't anything like a massive hemothorax. And then he got transferred downtown appropriately as well. So yeah, I think he's had a prolonged course downtown, but not necessarily anything due to interventions at Westchester or pre-Westchester. It was all sort of complications from surgery.
Yeah, most of what I think I saw that he got discharged to, I want to say inpatient rehab, and then had like one visit afterwards for some like post-operative pain or something minor like that.
Yep.
Cool. So for both of these, I thought they were good things to go over some chest trauma, and please, Dr. Sites, if I'd happy to have you jump in anywhere. But the big things that I could find on here is that chest trauma is like actually a major form of overall trauma that we end up seeing for patients, and it can be broken into like blunt or penetrating, but ends up causing damage to the chest wall as well as the contents therein. So that can include, as we typically think of, the ribs, the lungs, the heart, but can also include the major vessels such as the aorta, the vena cavas, as well as esophageal trauma. And then another one that we don't think about as often would be diaphragmatic or damage to the trachea and the bronchuses. Most of these, where the injury is located and what ends up happening to say rib fractures, where they end up going through the chest or anything else, will determine what ends up being injured. And then the other thing to bear in mind is that most people will end up having, in minor chest traumas, they end up doing okay, unless they have some underlying predisposing risk factors, such as elderly patients who don't tolerate rib fractures as well, and end up having a higher likelihood of complications, or patients with underlying pulmonary disease like COPD, pulmonary fibrosis, etc. As a reminder for any trauma assessment patients, I'm a pretty big believer in the March algorithm for trauma assessment, which starts off first by looking for massive hemorrhage, and this is massive life-threatening hemorrhage. So things that would require a pressure dressing placed for a large venous injury, tourniquet placement for arterial. I've actually started changing my own thinking where if it's a blunt traumatic patient, say in an MCC or an MVC, and I have concern for potential pelvic injury, I've started thinking of the pelvic binder as a management for massive pelvic hemorrhage as opposed to where we typically put it in circulation, just so that's not something that gets forgotten, as it oftentimes is, at least in my chart review. Airway is next to make sure we don't have compromised the airway, and it's mainly to make sure that it is patent and clear, or if it is compromised, to manage it. In respirations, we're looking at the overall work of breathing, the respiratory hemodynamics, such as oxygenation status, and their respirations. And the big focus in the pre-hospital setting for this is making sure we have a relief of a predominantly pneumothorax, and in some circumstances, a large hemopneumothorax causing tension physiology, which can be life-threatening. For most pre-hospital providers, this will focus on a needle thoracostomy or a needle decompression, but can also in certain circumstances be a finger thoracostomy. The next one is circulation. So making sure that we're supporting their heart function, their overall volume in the tank with either fluids or preferably blood products, as well as making sure that their heart is functioning appropriately. Some would say, and this is where you could assess for signs of a wide impulse pressure or signs of like cardiac tamponade, poor perfusion to the distal extremities with weak pulses, etc. And then the last one is the 3 H's, which is going to be head. So this is where your GCS comes in, as well as if there's concern for severe TBI, consideration of hypertonic saline, maintaining patient at 45 degrees, spinal precautions, etc. Hypothermia, as that is in the trauma triangle of death, where patients become cold and then they become coagulopathic. So making sure that after we strip our patients naked to look for any injuries, we then subsequently cover them up, and in certain times of the year, this may mean applying blankets, heating blankets, cranking up the temperature inside of the ambulance, especially if they've been outside, even in the summertime, like outside in the rain or the cold. And then the last one, hypoglycemia. We've all heard of the cases of a patient who became hypoglycemic, crashed their car, and that was missed, and ultimately would have helped their overall cardiac and metabolic function, having the hypoglycemia addressed promptly. In regards to the penetrating trauma, the things that I found that discussed it was that the ultimate severity of the trauma is typically secondary to the path that the projectile ends up taking through the chest. So this could be the projectile passing through, but then also what type of projectile you have. So one that is at a high versus low velocity, the size of the projectile, or the impact pattern. So say a shotgun where it's meant to disperse on impact is going to cause larger wounds up front, but may not have as great a penetration versus like a more high velocity round that's intended to go through objects. The other thing to consider is the potential shock wave from the fragment going, or the ballistic going through the tissue itself. And sometimes that can end up causing more damage than the actual fragment itself. And then the other thing is when the projectile hits the body, what does it do? Does it burst into multiple pieces? Does it end up mushrooming onto itself? Does it hit something like the sternum or the ribs as it's going through? Or does it end up breaking into pieces? And then the other thing that I found in the literature is that some of these ballistic fragments may end up traveling into secondary sites. One that I found a lot of case reports on was a ballistic fragment ending up in the large, either in the heart or in the large vessels, such as like the aorta, and then being sent off into a secondary blood vessel. Or the other one that we will see is where the ballistic fragment ends up going through the diaphragm and then into the abdominal cavity and potentially hitting the abdominal contents. One point in documentation that I would advise everyone is we are not credentialed to say that a ballistic wound is an entrance or an exit wound. So I would advise avoiding against documenting that in your notes. That is actually something that people have to have specific training in, and even I don't have education on that. So usually what I would recommend people say is that there's a ballistic injury as opposed to trying to opine on if it is an entrance or exit. And that can be challenging when you can literally see the bullet right next to their skin. But to be on the safe side from you from a medical legal standpoint, that would be my recommendation.
Yeah, just to echo a couple things, definitely is important when we are talking about the missile, whether it's high velocity versus sort of a more standard projectile. That really changes my thinking in real time pretty significantly. If it's one of those high velocity rounds, even if the external injuries don't look terrible or the patient is like holding their own, doing okay, my level of concern is increased exponentially just because the internal damage from those can be devastating. So good point on that, and that's definitely something that perks my ears up.
Awesome. Thanks. Awesome. And then in the blood trauma world, this is usually from a chest or a force onto the chest wall. The most common ones that I found were fractures such as particularly the ribs, but then also sternum, and then involvement of the pulmonary systems. This could be contusions, pneumothorax, hemothorax, and a lot of these were thought to be from damage from a close by rib fracture that ended up like cutting through the pleura or cutting through the lung from what I could find. And then another thing to always consider on these patients is that you have large forces that have put on the chest, and this may end up causing cardiac injury. Blunt cardiac injury is not as common as, say, rib fractures, but is something to be concerned about in patients if you start seeing hemodynamic compromise. And you may also see, particularly in things such as a high-speed MVC, could see damage to the great vessels, such as a traumatic aortic dissection, where you end up having a cut through the aorta from those stopping forces. And that can potentially lead to cardiac tamponade if you have that dissection that goes through the blood, goes through the aorta, and then goes back to the origin of the heart. So these are things to bear in mind when you're considering your patients with chest trauma. We talked a lot about needle decompression. It's one that I think is always worth going over, as it is a procedure that can be life-saving in the pre-hospital setting. This is done to relieve a pneumothorax, particularly when you have concern for tension physiology. There's two locations that you can do this. The first is in the second intercostal space on the mid-clavicular line, so middle of the clavicle, second space between the ribs. The more common one that we have been moving towards is fourth or fifth intercostal space. I'm usually an advocate for the fourth so that you stay away from liver and spleen. And that is in the anterior axillary line. And it is actually important to make sure that you're in the, the anterior line of the armpit, because if you go in the midline of the armpit or the mid-axillary line, you run risk of hitting some major nerves and blood vessels in that area. That could end up causing further trauma, bleeding, permanent vascular or neuro damage to the patient that we don't want to have. When you insert your needle, you want to go in until you feel just that pop through the pleura or get a rush of air back, and then advance the needle no further, but you can gently advance the catheter. And one thing to bear in mind with the needle decompression is that this will do pretty much nothing for a massive hemothorax, which we'll talk about in a moment. So these are probably the two most common ones that we'll see outside of rib fractures, is a hemothorax and a pneumothorax. We've all heard of pneumothorax, which is the collection of air inside the chest wall cavity, but or pneumothorax is the air. Hemothorax is blood inside of that pleural space. Both of these can end up causing tension physiology, which is where these abnormal substances, blood or air, end up putting pressure on the heart or the major blood vessels, such as the aorta or the vena cavas, the big veins that come back to the heart. In your patients, they may both end up causing hypoxia by pushing on a lung.
They can cause tachypnea because these patients have less pulmonary reserve. It can cause, ultimately can cause hemodynamic compromise, and you may see absent lung sounds in both of them. Oftentimes, if your patients are supine, you'll hear more of the absent lung sounds at the apex if it's a pneumothorax, but at the base, you may hear some absent lung sounds because gravity will have blood settle in that posterior part of the chest. And you can see these both together depending on what is damaged. The problem with a hemothorax is that it's not something that's going to be relieved by our needle decompression, because that needle is just not a large enough caliber to allow significant blood to escape from the chest. So oftentimes with patients, if you have a hemopneumothorax, you may have a rush of air, but they're still not having a significant improvement in their hemodynamics. And that's because they have all of this blood in the bottom of their chest that's pushing on their heart and their great vessels. And that really needs to be relieved by a finger thoracostomy and probably ultimately a chest tube, depending on the size of it. And then the last thing that I was looking at was chest seals. Most of this I found in the Journal of Special Operations Medicine, which I did not know was a thing, but is pretty cool. And most of their literature was coming out of special forces, so people working in the military. Their analyses they found looking at several papers with that chest seals are still recommended in the pre-hospital setting. Because these can end up preventing tension physiology by allowing air to escape out of a valve, but then not be brought back in. The problem with these, though, is that you have to make sure that when you place these on, you are allowing that air to be exhaled or intermittently burping them, as this team did, to make sure that you're not creating a tension pneumothorax by not allowing that air to escape when patients are exhaling. So right now, these are still recommended, but the biggest caution that I would give people is if you put these on, particularly, I've seen it in the shrew, actually, where you put one on both sides of the chest. If you're not making sure that you have air leaking out with patients' exhalation, you may end up having them continue to trap air in the chest and may end up causing more problems. And those are my big things that I had. Would happily take them for Dr. Richards, Dr. Seitz.
Perfect.
Otherwise,
So,
I think it's your turn, sir.
yeah. Real quick, I just want to go over a couple of things on the side of the police side. The second example she gave, the gunshot wound came out as a
Do you want to be on camera or no?
came out as a unconscious or non-breather. Life squad gets here, it ends up being a person who had shot himself. So I want to first say that over the past couple of years, we've worked well together from the police and the fire side to be able to work a lot of traffic accidents, understand what evidence is and not destroy the evidence, be very careful doing that. When you guys arrived on the scene of this, the police were not on the scene at first, which is could be the norm. Fire arrives on the scene first. The situation is he's laying in the yard. We go inside and find a gun. There was a lot of questions on this one, whether he had actually shot himself or the wife had shot him. They didn't know. And rightfully so, the police weren't on the scene yet, so the fire department did the best they could with having the weapon there, utilizing all the resources in the room to secure it. So I just want to talk a little bit about how you should go about securing that. If you need to secure it, a lot of times staffing doesn't allow us to have the staffing to put somebody specifically to watch that gun. But a lot of times where the weapon is can lead us back evidentiary wise to figure out whether or not they shot themselves or it was actual murder or attempted murder, suicide, or some of that. So just real quickly, just wanted to, if you have to get that situation, the best plan of action is to provide one person to stand by that weapon and not move it, not touch it. That is our 100% preferred method. However, we realize that we can't always do that. So the next best thing is if you can quickly take a picture with your phone, that's great to just tell us where it's at, what the angle was, what direction it was pointing. If you've got to move it, obviously you have gloves on already, make sure you're moving the gloves, putting a secured location in the back of your car, in a drawer real quick, or something of that matter. But make sure that if you're looking, if there's any type of blood on it or evidence like that, just kind of try to pick it up with 2 fingers and move it to where you need to move it to. But again, the preferred method is to obviously keep it where it's at. But we understand that, especially in that scene, neighbors were there. The wife was walking around. We thought the wife might have been involved. So you want to secure that weapon as quickly as possible, because for the police side, we just thought it was an unconscious male, and we're not going to like to siren that because it's not something that we go like to siren to. So, this would work a lot better if there's more questions. So, what I'm gonna say to you all is, reach out to me via cell phone. You've got my email. If you have any specific questions, specific ways to handle scene security, call me and we'll get that figured out rather quickly for you.
So, and just kind of for my thoughts, so if there's a weapon on scene and there's, ideally, we have one person just there, numbers wise, it's probably gonna be challenging, at least move it out of the way and kind of, if someone has firearm experience, should they go through the process of like taking out the bullets and these sort of things, or like?
We would prefer to keep it intact,
Yeah.
just so we can say what type of bullet was in it. I mean, we can always go to the fireside and get a statement of what it looked like and where, you know, but in the, you know, interest of the scene where they're stressed and going like that, they may not remember if the bullet was in the chamber, if the magazine was in or not. It's best to leave it the way it was, so we know how many, if the bullet's in the chamber or not. That does make a difference to us when one was fired and the ejector didn't eject the bullet out. But another thing I'll touch on real quick too is cutting off clothes and stuff. That can give us a lot of clues of what's going on, so just be mindful if there is a bullet hole in the clothes or trauma in the clothes, maybe try to cut around that hole, so we have the hole intact. Take them off, you know, if you've got a bullet hole from the front of the shirt, cut it off the back, or the back of the shirt, cut off the front. That way we can kind of piece that clothing back together and have a whole picture versus just cutting it straight through the trauma zone.
Okay.
Where it's harder to, you know, move that and look at it and kind of create that picture. You gotta think what we're trying to do is create, you guys are trying to obviously save life and do it the quickest way possible. And we're trying to piece evidence back for a jury to say,
Right.
and put that shirt on a mannequin if we have to say this is where it was. It
Sure.
also helps us when we're recreating the scene we can put different evidentiary type stuff we have, you know, ballistic rods through and see
Yep.
kind of what angle it went through and stuff like that. So it really helps us to have as much evidence as possible when it comes to recreating that scene for us.
Is there anything, because that first one, like even the EMS spreadsheet commented on like this trail of blood that was like going places, is that gonna be helpful to any part of this, or?
Yeah,
or
I mean,
is there,
blood
like,
trail-
Cots over it, or?
Blood trail is huge for us because in blood recognition, you can see whether the person was running, walking, standing still based on the type of blood drop it has. Not to go a lot into it, but it'll trail, the head of the blood trail will go towards where you're at if they're running a certain way. So we can tell which way a person was moving as they got shot or as they got stabbed based on the blood trail, or if they were standing there as pulling blood or whatnot. Not really what you guys have to worry about, because most of the time the blood trail, we're looking a couple rooms away, or you know, where they ended up at is not most like, because they got stabbed where they're at, it's gonna pull, where versus the trail of they get stabbed over here, then turn around and walk into a different location. So, but it is helpful. That's an issue.
Is there, I don't, sometimes we think about this, like when we're in the emergency department, and like someone ends up dying. But even like in the pre-hospital environment, like they're gonna be putting needles in the chest and these sort of things, maybe it doesn't take, or maybe they have to reposition. Does it matter if, from a medical perspective, if it doesn't matter if the kind of a first stick and a ID into the chest wall, they have to repeat it? Does it matter if they take it out or they have to leave it in, or anything that they end up doing to a victim?
That is
kind of be
something that's gonna
same
be with
place?
the coroner.
Yeah,
During what they like. When it comes to the autopsy side of it,
yeah.
that's basically what your report is gonna say, where the coroner can do that. As far as evidence goes on us, we're not worried about that. It's
Okay.
just what the coroner needs to interpret for the autopsy side of it.
I get it. Okay.
Okay.
That's what I got too. Anything for you, Dr. Seitz?
Engine 71 information, Butler County Medic 113 will be on fire ground.
No, that sounds great.
All right, thanks for joining. Sorry for all the technical difficulties.
Oh, no, thanks for having me.
Thanks again, guys. We will end this now, and everyone have a good rest of the day.
It's gone.
That was super interesting, thank you.
Yeah.
Yeah, no, if you guys have any questions, let us know. I'm not
Yeah.
obviously a detective, and I can get you guys in touch with